Perfect.
We got the go ahead. All right, great. So welcome everyone. Really want to thank you for joining us today as we kick off PSW's webinar talking about care management. And we'll talk a little bit about some of the triumphs and trials as we work through our care management program here at PSW with kind of a population health focus and lens. So really appreciate you all joining us this morning. I'll go ahead and introduce our speakers. My name is Jake Woods. I'm the Executive Director of ACOs here at PSW. I'll be a little bit of kind of the moderator today as we'll walk through a couple slides explaining some of our care management services, talk a little bit about what we provide, and then get into kind of an open discussion about some of our experiences when it comes to care management. And then we have Dr. Michael Shannon, so I'll have him introduce himself.
Hi, folks. Michael Shannon. I'm an endocrinologist by background and the Chief Medical Officer at PSW. Cheryl?
Hi, good morning, everyone. I'm Cheryl Moses. I am the Chief Nursing Officer here at PSW.
Great, thank you. Just a few kind of housekeeping items before we go ahead and get started. Everybody is going to be muted throughout the event, but we do have that Q&A box that you can go ahead and submit questions through. So we'll be watching and we'll do our best to kind of address those throughout the webinar. We'll probably have some time at the end if we want to kind of wrap up with some questions that we didn't get to during the webinar, but please feel free to submit those as we go along. We want to try to incorporate those into today's discussion as much as we can. For those who are on the LinkedIn event, you can submit questions as well. We'll be monitoring that and making sure those make it into the Zoom so that we can see those as well. Now, as we go through today, really kind of our main goals for the webinar and as we talk about care management is make sure you as attendees have an understanding of our care management programs, but really the importance of having a certified care management program in supporting value-based care arrangements. And I'll talk about that a little bit with the PSW journey, how we came to be in population health and value-based care, why we put such an emphasis on care management, and why we think it could be really beneficial to, helping and supporting your patient populations. So really the importance of that certified care management program that we built through NCQA certification. What does that mean? Why was that important? Also looking at the effectiveness of building relationships with your providers. We talk so much for those that have experience in these value-based arrangements that physician buy-in is crucial to be able to be effective in these programs. And that comes with care management just the same. So you have to make sure that you have that physician buy-in and that they are a partner in this. They understand what we're trying to do. They're sending patients over and they're really furthering these programs just as much as the care management teams are and how that can be helpful for patients. And then really about how we use care management to support whole person health, not just an individual, at this moment in time, support them for a couple of days and move on. But what does it mean to really support the person as a whole through their entire healthcare journey? And how do we support them for an entire population within a given arrangement? Now, a little bit about PSW and who we are. So PSW originally stands for Physicians of Southwest Washington. We dropped that a little while ago because we're not just in Southwest Washington anymore. So we go by PSW. And we were originally founded in 1995 by independent physicians. We started out as a true independent physician association for providers and small practices in Olympia, Washington, Thurston County area, and have since kind of grown to support other types of providers and other types of groups across Washington state and now outside of Washington state. And really at the core, when we started, and still at our core today, is about how do we support providers in their relationship with the patient and improving the quality of care, and then working towards the quadruple aim, right? Improving population health, enhancing the patient experience, reducing provider burnout, and reducing the total cost of care. How can we support providers and groups be able to participate in these programs, be as successful as possible, and make the healthcare experience and the outcomes much better for the patient's populations where we can? So that's been our goal throughout our entire experience. We made a shift right around the time of the Affordable Care Act and went away from our true IPA, Independent Physician Association model, and really focused to become a population health company. And so what that means is now we've invested in the services to support all elements of value-based arrangements, whether that's standing up our Medicare accountable care organizations that we've started and participating with various types of groups, or becoming fully delegated for risk in Medicare Advantage or other types of groups. We can pay the claims. We can do the utilization management. We can really make sure that we are there supporting the providers, helping them through the experience and making sure that they're included in the decision-making as we go through everything that we do with our partners. And so now we've grown that. We now have multiple accountable care organizations. We have multiple different contracts that we employ, and we have our advisory and management solutions. And so what that is really the ability to break off a piece of most any of the services that we provide and offer that to providers, health systems, other groups that are participating in any type of model, really. And so that's today we're talking about care management. That's just another one of the pieces that we talk about. And through that growth that we've seen, we're now managing about 400,000 lives across the country. Like I said, we're not just in Southwest Washington anymore. We're really kind of grown to across the country, supporting all different types of providers, from independents to health systems to rural health systems with critical access hospitals and rural health clinics, really kind of across the continuum. How can we support all of those types of providers in the transition from volume to value, and really focusing on value-based care and population health management? So as we kick off here and start talking about care management, I wanted to do a little bit of grounding, right? A little level set on what is care management, or at least what do we think care management is. I think it's not necessarily a new concept to anyone, but we do see sometimes as we work with people that there can be some difficulty in the distinction between care management and case management. So really wanted to talk about care management. And that's really the team-based approach, focusing on coordinated care to manage the individuals to get the right care in the right setting. And we kind of take the population view, right? We are not just, like I said, doing the patient day of once or two, engagements and call it quits. It's really about how can we follow those patients throughout their experience, and sometimes engaging them months and months at a time, or years over year. And we've had patients that, they get to know our nurses. I think we've had some that they've sent holiday cards, and they've really, shared stories about Nurse Melissa was so amazing. She did all these things for me. And so it's really kind of getting to know them on a different level, and really being that team is being that quarterback for these patients as they go through their healthcare journey. And then taking a population health view to that, right? The distribution of health outcomes within an entire population. So much of what is affecting a patient's care or a patient's health is outside of the provider office. So how do we make sure that we're understanding what are all of those determinants that are influencing their outcomes or their healthcare experience? And how can we, as a care management and population health company, develop interventions and programs, or work from the policy front to figure out how can we support them in the best way possible and make their care experience even better, improve their outcomes, and at the end of the day, reduce cost of care, create better financial opportunities for the health systems and provider groups that we're working with. Now, as we go through this and we think about our philosophy, I think I'm kind of getting the message across, right? We take the population view. We really think of all of the aspects as much as we can, the whole experience, but also the whole person and everything that it means to be a person. It's making sure that they have some self-management techniques. They feel confident to make informed decisions about their health. So much of a patient's experience might be anxiety-filled or confusion because they don't understand their condition. They don't know who to go see. They don't know what resources are available. So how can we really make sure that they feel informed, they feel confident in making their decisions? They can ask the questions, they can find their resources, and they can just feel more comfortable and more in control of their healthcare journey. How do we educate them on the awareness of additional resources or community organizations that they could connect to? They might need help in certain areas that a provider in a provider office just can't provide. And so from the population health view, how can we find those services? How can we connect them to those services and make it available for them? One instance I think of sometimes with our care management department is in our Medicare ACO. We might have beneficiaries who are dually eligible for Medicare and Medicaid, but have not applied to Medicaid. They either don't know how, didn't know they could, weren't sure, how to get it done. And so our care managers are actually able to identify that, work with them, get the application filled out, and make sure they get connected to the resources that they need. And then lastly, just promoting the wellness of the entire person, more than just physical, but the person as a whole, the spiritual, the social, the cultural, and the psychological. All of those elements are so crucial to a patient's care experience and their overall health. So how can we build programs that are really supporting them and making sure that they feel confident in all of these areas? Now, taking this a little bit more technical and getting into our programs and what does that actually mean? What are we actually doing here? It's really focusing on a few key areas we think are key levers of population health that we need to influence to help these patients, right? Acute care. They go to the emergency department. They've gone inpatient. They're getting discharged. How can we make sure that their transition is smooth? And it's not just making sure that, they understand their discharge instructions, but making sure they understand their medications. They have a follow-up scheduled, making sure that we are coordinated with the case management team. There might already be a case management team over at that hospital. So how can we make sure that they're aware, we're aligned, and that we're doing a single unified approach to manage this patient rather than this discombobulated, confusing approach that might be challenging for the patient. Post-acute care. How do we follow these patients through the skilled nursing facility or through their home health experience? Make sure that they are getting the services that they need. They're getting the follow-ups. They're understanding the connection between maybe they got discharged, from acute to skilled nursing facility, making sure that transition is smooth and that they understand the instructions and that these patients are engaged in that entire process. They feel the shared decision-making. They feel in control of the experience that they've had. And then kind of your standard other services, right? Primary care, urgent care, preventative wellness, these elements of care that are so important for the patients to be able to take advantage of, but then also taking that one step further. We look at some in-home and mobile ED services or addressing social determinants of health and really connecting them with those resources that they can take advantage of. That's going to, get them to the provider if they weren't able to, or whatever service it may be that's going to help them just in a little bit of a different way. And how we do this, how we look at the population, is really making sure that we are identifying for our partners what segment of the population is going to have the biggest impact. And so that's identifying our high utilizers, our high risk patients, and making sure that we are wrapping around them and doing as much as we can to support that population, because it might be the top 10% highest risk of the population is going to have a greater impact than the other 90% if we manage them effectively. So it's about using our resources and our partners' resources in the most effective way possible and touch as many patients as we possibly can in the right way to get them to the right side. Now, when we break up PSW's care management programs, we kind of have these buckets, in how we think of it. We have our short term, right? I talked about that. That's the acute care, our emergency department transitional care management, and our inpatient transitional care management. How can we make sure that these programs are built for these people and that they're getting those discharge instructions and getting those connections, and we provide that. The kind of second bucket of what we provide to various partners is our longer term care program. So this is short term plus. We do the transitional care management, but this is also where we start to engage with the patients and getting them in some of those longer term programs, getting them in general care management, getting them into complex care management program. Maybe it's a COPD focused program, maybe it's a CHF focused program, making sure that those patients feel confident in their disease. They have a connection. They have a nurse, Melissa. They have that quarterback that's really helping them throughout their journey, feel in control and getting their follow-ups, getting needed services, getting needed visits they need while they continue throughout the year. And then lastly, our specialty care management program, which is pretty much everything from the beginning, plus taking it one step further, really engaging in the post-acute care management. And Cheryl will talk a little bit about this in, how we've engaged with various skilled nursing facilities. It's not just making sure that the patients themselves have a great experience in the skilled nursing facility, but how are you also working as a group with those skilled nursing facilities to make sure that they are working towards the same goals you are, and that you are in partnership with this as you're managing this whole population. You're in partnership with what the goals are and making sure that everybody is working towards that same North Star. And then services like remote patient monitoring, right? How can we get as much up-to-date data as we can, get that over to the provider and make sure that there's that connection, that there's that ongoing management and just making sure they're informed. Part of the challenges we see within the healthcare system is just disconnected. Providers might be blind to something that's going on with the patient because a discharge, notification wasn't sent or something was missing along the way. So how do we build those bridges, build those pieces, and really make sure that we get all of that information over to them? Now, that's a lot of kind of the structural pieces. I really wanted to go through the overview of what are our services, what are these elements that we talked through. I know I want, Cheryl to be able to talk through what are some of the results. What have we actually seen from these programs? How do we think it's been effective for the patients that we've worked with? So Cheryl, I'll go ahead and pass it over to you.
Okay, great, thank you, Dave. So one of our targets as we do transitional care management has been to reduce ED visits, and one of those areas, of course, is the avoidable population. And so in this, we have really focused our attention in providing education to the population regarding what reason they're using the ED. So this is just an example of focusing on the avoidable ED visits that we had. So this is a population that is fairly stable that we're looking at related to this outcome. So between 2019 and 2023, we've seen a consistent decrease in the avoidable utilization. Now in 2021, we see a significant drop there. And that was during the COVID time where we saw a lot of people who were staying away from the ED, and especially this population, the avoidable ED visit, where they were making the decision that I probably don't want to go to the ED. And so following that, we started to see the bounce back up, but we were still below where we started, and we've continued to see that decline as we have continued to provide education to this population. And so we have different measures that we do as we focus on avoidable EDs. And one of the things that we really strive to do is to focus on the why. Why are people going to the ED, and providing that education based on their why. And as Jake mentioned, developing that nurse-client relationship as we're doing our engagements with these folks. We have different people who use the ED for avoidable reasons, and it could be those who repeatedly go to the ED instead of having a provider. They, have the ED as their provider, and so these folks, we really try to focus on, again, the why people are using the ED and help them to connect with a provider, understand the holistic needs of the person, as Jake was kind of really referring to. Is it SDOH related that they're using the ED? We've had people who have used the ED for mental health anxiety reasons. And so they will use the ED over and over and over again. And so we've had care management team members who call these folks on a daily basis to provide that additional support and have seen a significant reduction in their utilization of the emergency department. So also, as we talk about population health and looking at who's using and why they're using the emergency department, one of the things that really has been something that stood out is the high utilization for UTIs among the avoidable ED users. And so we initiated a program and did some education. So we've created some tools and also have educated our staff on things that we can do to support these individuals on how to obtain assistance for their UTI. One of the things that we provide services for commercial, Medicare Advantage, ACOs, and different types of programs that are available out there. And so we really tailor our programs to focus on the population that we're serving, what's in their area. We serve people who have no urgent cares in their area. So they just have an ED because they live in the rural areas. And so again, we really try to focus on the needs of the population and where they're living so that we're using healthcare to its appropriate location. And So we really focused, again, on ED utilization, and we saw a significant decrease in utilization through our program of 11.8%. And then in the beginning of the year, every year we have new population coming on, and as we're expanding or people are joining different programs. And so we saw again the bump up in the beginning of 2023 of people going to the ED for UTIs, and then we implemented the program with this new population, and then from there we saw an additional 15% decrease in UTIs, and we continue to focus on this as it's a significant need in teaching our populations. And then finally, wanted to share about our post-acute management. So for our post-acute management, when we provide care management services, we follow them throughout the entire year. Wherever they are, we are engaged. And so one of those areas, of course, is post-acute and skilled nursing. And so when they're in a skilled nursing facility, we engage those facilities, and during that engagement, we're looking at helping the facility to manage the length of stay, but also to support the transitions of care. So during those engagements, our teams are really focused on specializing in what each one of the payer programs, what their benefits are. So that way, when we know somebody has a special need to support social determinants of health, they know what their benefits are available, and also the community. So we really help the facilities to ensure that we're focusing on making sure that those needs are met. So it's not keeping the person in the skilled nursing facility longer than they need to be. And with that, also we engage our acute partners. And so we can also help support making sure that people who need to go to a skilled nursing facility are going there, and those who can go home, that they're going home. And when they go home that way, we can also provide that's complex care management services. We also have the remote patient monitoring services to help those folks who can go home to be at home. And then really, they'll follow up with them in that setting. And so this graph just shows you over time that we've had a decrease in admissions. We did have, again, in 2021, you can see a little bit of the COVID in there. People started to stay away from skilled nursing facilities because it was the focus of where COVID, was rampant. And so people on their own were deciding not to go. So you can see that drop. But, as we continued post-COVID in 2022 and then 2023, we're still waiting on run out, but we're still looking good for 2023 regarding the admissions and the utilization. And so our focus here with our partners is, again, to make sure that those who need post-acute are going to post-acute, and then also managing that length of stay. So we can kind of see that when we get the right people in the nursing home, the length of stay may be longer, but we're showing that that there is a reduction in that PMPM, or the per member per month cost overall for skilled nursing facilities. Now, in 2021, we saw the impact also of the changes CMS and paying out to skilled nursing facilities. And so there was an increase in cost there. And so we're still seeing that in the PMPM, but it's still lower than it was because we're utilizing post-acute better. And one of the things that we do with our post-acute management program is in engaging our post-acute providers. We share information. We're unblinded, so facilities are very competitive. They want to be better than their competition, and so we unblind information. And so we have these quarterly joint operating committee meetings with them to review performance. and really discuss our partnership and how we can improve that partnership and reduce readmission. Readmission is a significant focus for us in our post-acute management program. We have a community program that we do to reduce the risk of readmissions, and we invite post-acute and home health and other partners in the community to talk about ways that we can reduce readmissions. One of those things is using the Interact program, if you're familiar with that. It's a program that's specifically developed for post-acute. They have different programs related to whether you're assisted living, or if you're home health, or if you're a skilled nursing provider. And so we do a lot of training on how to use those programs to reduce readmissions. We've gone into the facilities and done staff education, and really helped facilities to understand how they can improve. And so we've seen a lot of improvement as we continue to work with our partners on that.
The post-acute care element is just so important. And as I love, Cheryl, as you talk about kind of the partnership and the JOCs, I think when I think back to our time as a next generation ACO a few years ago, the post-acute care management was a huge element to our success. We spent numerous years where we were in the top 3 for all next gen ACOs for lowest cost of care per beneficiary in post-acute. And I think it's interesting to think about the ways that we incentivize those kind of providers. This is not, like we talked about with the population health view and with some of these arrangements, this is not a we are doing this over here and you're doing this over here and you're doing this over here. It's really how do we come together. So having that unblinded, kind of data and inciting some of those competition can be great. But then I've also heard groups, ask about, are you incentivizing the SNFs financially? Are you including them in shared savings? And, we've tested little bits of that. We've done some where we don't, we've done some where we do. I think it can be effective in some ways, but I think really seeing this kind of community collaborative approach that Cheryl has created here has been a bit more effective and more engaging with those facilities, kind of top to bottom as we work with them. So as we kind of move in to our discussion portion and talk through some questions, I know I saw one question asking about mental health. I think I saw Dr. Shannon answer it, but we want to probably kick off with that live. So I'll kick it over to Dr. Shannon.
Perfect. And there's a second while I'll take a swing at that. So great question come in, which was interested in hearing how and when you've incorporated behavioral health into care management. What have been the challenges? I think the number one challenge is we can't find any mental health providers with open panels. It's not much of a hyperbole. We have really struggled in our community to be able to find people with open panels, especially to take those with Medicare. In some ways, because of the federally qualified health systems, at least in our state, Medicaid can be easier than Medicare sometimes. So what our team did was bring in a pair of social workers for different contracts, and that has made a huge difference. They have MSWs with training, especially, we have one plan with 31,000 commercial patients, and the explosion, especially in teen and mental health and substance abuse over the last 2 years, has been pretty profound. But even below the social workers, the nurses are fairly well trained to be able to identify basic tools of anxiety coping mechanisms for substance abuse, where to find 12-step meetings, and are able to do a certain early layer and then escalating to the social workers. And then Cheryl touched on, we do interdisciplinary rounds, social worker, doctor, nurse, where you review these, which is, hey, you know what, maybe this person is a good candidate for naltrexone for their alcohol use disorder. Or there's actually a great neuropsychiatry program out of this city, and maybe we can get them enrolled in the outpatient day program. And so that's the behavioral health part, especially focused on elders, and substance and the teenage elements have been the biggest rises. And those are 3 of the tools that we've used to address them. Cheryl, anything to add there?
No, thank you, Dr. Shannon. I think
great question. And the mental health shortage in most communities, we've tried to use virtual as a partial backup. I'll give you my frank answer on that, which is a lot of the virtual health ones will have profiles where the same mental health therapist will do geriatric dementia, teenage grief, eating disorders, and schizophrenia, which, sometimes when I look at those reminds me of I cook tortillas, pasta, and Chinese food as well. And it makes me nervous when we see some of these that have such an open palette, and trying to be able to find people locally. And in places where we are not local, we've worked and figured out who there can be our resource from the group that's contracting with us.
Great. So as we kind of launch into the discussion, we've talked a little bit about what are the care management programs. We talked a little bit about some of the results to patient outcomes, but I want to kind of hone in on the patient a little bit and patient engagement. I think sometimes we hear from some groups, patients don't necessarily want to engage in care management. They don't understand it. They certainly don't understand what like an ACO is or what groups are doing. And so really diving into, how do we effectively improve that patient engagement, especially from the PSW lens where we do not employ any of our own providers. We are not the group that is providing care. We are completely separate brand. So how do we outreach to these beneficiaries who don't know what PSW is, and how can we get them to enroll in services and help them understand how we are here to help, how their provider has chosen us to be able to help them, and kind of get them to engage in services. And so maybe I'll start with Cheryl, a little bit on what are some of the strategies that we've implemented here at PSW to improve that patient engagement?
That's a great question, Jake, because that's been one of the areas that I think has been challenging for a lot of folks who are doing care management. We have done several different things on engaging our clients. One, we've created a letter which we mail out to let clients know that they're eligible, which we co-brand. We make sure that there's a tie between us and their provider and their health insurance, so that way they know who we are. We also educate our provider offices groups so that we're really engaging the providers. So we have a really great connection with the population when the provider is involved. And so we really make that a priority to make sure that the providers are aware of our services and that those referrals can come from the provider. So those are just a couple of the things that have been successful for us. We've been really successful in engaging our clients in that when we do call them, we try to strive to make sure that we're doing something for them. It's not just about calling them and asking questions, but we're trying to identify if there's any gaps. Is there any way that we can provide services for them? So, we kind of talked about mental health, and I kind of shared about the use of ED. So when we're discussing with people and we're looking at what's driving their healthcare utilization patterns, then we're able to determine what we can do to help them. And so that again has been a key factor in really developing and building those relationships. We have population people that have made such great connection with their nurse care manager that it'll be a couple months later and they will reach out back to that nurse and say, hey, can you help me with this? And so that's been a really important factor.
I'd love to hear Dr. Shannon's thoughts as well, especially coming from the provider perspective. You were a provider in the community before joining PSW, kind of your thoughts on that as well.
So if you asked me the scariest moment in my medical career, and it was not the time I had to do a tracheostomy on somebody, it was the time I had a patient who was a victim of domestic violence and having absolutely no idea what to do next. And I was more prepared to handle a patient in the ICU on a ventilator than I was to handle social challenges like patients telling me, I've lost my home, or I am having an issue at home, domestic violence, or I'm concerned about taking my own life. And the ability to try to relay, you touched earlier on behavioral health, but the ability to have someone behind this, or the element of, I don't know how to, I used to do home visits. I was a geriatrician before endocrine, but the ability now to have someone to deploy, to reach out between visits, I would say that I was great at providing episodic endocrine care, meaning if you by some fortune of scheduling stumbled into my office, I was at least an adequate doctor, but it was all the visits between there, and there's questions in there about RPM. And there was the people who don't come in and see me, or what happens between, is where most of the chronic disease falls apart. And having a team like Cheryl's to be able to get them done between visits and to handle the broader social determinant issues for which most providers are woefully underprepared and to some degree terrified, and I would have included myself in the same. I think that's what really can be offered with care management.
Yeah, I'd like to go back to the RPM, trying to answer that question specifically, since you brought it up, Dr. Shannon, that's okay. So we use our RPM, kind of when we're doing outreach and we're identifying people who are higher risk, and their utilization maybe, or they've had a new diagnosis of CHF or COPD or some other type of chronic illness. Our goal with that is to help them to understand their chronic disease and to be aware of their signs and symptoms and what to look for. So we use remote patient monitoring as a way to educate. And so when we're identifying, again, the high-risk folks, it's not just those who have used the ED, 10 times over the last year for CHF and have had 3 inpatient stays. It's also looking at it from a preventive measure for those, like, again, those who have a new diagnosis. And so we, again, use it for educating. And so we will educate them on, what does it mean to weigh yourself daily? What should I be looking for when I'm weighing myself daily? When do I call the provider? And, what does my blood pressure mean? What does taking my oxygen saturation level mean? What does all that mean? And then what do I do with the information? And then after we've educated them on providing opportunities to improve self-management, understanding things that they're doing, changing modifiable risk factors that, we can work on with them, whether it's diet, exercise, and, those types of things. Then once we've graduated them, we actually pull the equipment out. We give them their own equipment, and then we continue to engage them to make sure that they have continued to do that. So, that they're continuing to weigh themselves or whatever we're trying to work on. We've actually used remote patient monitoring also to help people lose weight. It provides them some accountability, as we're trying to improve health and wellness.
Sure. Cheryl touches on the graduation portion. When someone leaves the hospital with an unstable diagnosis, they are at high risk of readmission and at high risk for cost. RPM tools aren't cheap, and deploying a high cost, high staff intensity tool makes sense when people are at a certain high risk. But then if you were to keep these people on it, and many of them start to feel a sense of security, if somebody starts to figure out at what point does it make sense to wean them off of this. And scripting here has been helpful, and the graduating message to not make them feel like it's being taken away from, but to let them know is they have gotten through this period of high risk, learn their tools, and scripting that you have graduated is a way to ease people off things which are no longer, from a staffing and economic point of view, necessarily a good balance. And so trying to make it a positive experience, which is you've been able to keep your oxygen saturations over 95% for the last month. I think you're doing great, and Cheryl's team is scripted to do it. Jake, I realize when I've been answering some of these, they temporarily disappear in here. So there's at least 2 that I've told people I will get to them, and I feel like I am at risk of under delivering on my promise.
That's all right. I think I can see them. So I think what's
Okay.
next is getting back to post-acute. So the question was, how has PSW been managing data and driving the post-acute care management initiatives? knowing that the most complex element for most organizations has been getting a single view of the underperforming areas and identifying the most vulnerable populations.
Well, we
So-
use, we pull in the data, so we have claims data that provides us a look. We're able to look at that data by regions, by populations that we're serving, and get a good idea. And so from there, we're able to identify where we need to focus our energies. If we need to go in and offer, again, training for the facilities, we've done that based on their performance and their level of engagement. We also, because we do it live in claims, there is some lagging. We also track performance as we go. So we provide care management services in our population health tool, and then we're able to identify again from those entries how we're doing, and able to see length of stay, readmissions, and information regarding how the population is doing. And we're able to then, because we've developed that relationship, go in and have conversations with the administrator and the director of nursing based upon and if we have any concerns. And then Jake, do you have anything else you want to add?
I think it just really speaks to the importance of using a tool like an Incentivizing, population health platform that's not only bringing in all the claims data, but for us, it's, having the claims data and the information all in one setting across multiple of our populations. For us, like I said, we have Medicare ACOs, we have other types of contracts that we're managing. How are we making sure that our workflows for our care managers are as standardized as they can? They need to be different based on patients and populations, but how can we get some standardization, have it all in one place, and use kind of that process? That's where having a tool like Incentivizer's been really helpful for our group and our population.
And not just Acute, but also like when we're doing population health and we're trying to identify from a care management perspective, where can we provide the most assistance to our population, we're able to drill down and look at utilization by area. And so maybe we have a county or even a provider group where we're seeing a higher utilization, or they have a higher incident of, say, CHF or COPD or something like that. And we're able to work with that provider group and come up with interventions and how our care management team can support the population specifically in those areas using the information.
You want to do the pregnancy question?
Yeah. So next that was on the list, has there been any focus on prenatal and perinatal MCH supports and resources into care management? So Dr. Shannon.
Yeah, so great question. Jennifer Shannon is a physician, my spouse, and her dad was an OB-GYN. And after going through most of the prenatal visits, Jennifer said, if we were not 3 doctors, I would have no idea what is going on in my pregnancy. You go in for the visits, and I had the image that was, you go in for prenatal visits and they tell you what to expect and all the different elements. And it may vary, but I understand they're very pressed for time. There is way less education than I would have been led to believe just as a lay person. So there's also a big gap. A lot of our younger women don't have very well established primary care providers. Some do, but a lot of these people have been sort of tenuous with the healthcare system, get pregnant, and then are thrust back into it. And they end up in a gap between the OB-GYN, who is doing very specific obstetric care, maybe hyperemesis of pregnancy. But what else happens during that? The asthma, the migraines, the GI problems, that ends up in a gap if they don't have a strong primary. And even if they do, a lot of these issues fall into between the primary doesn't want to do it because they're pregnant, the OB doesn't want to do it because it's not clearly obstetrical. And that's where our team has done a lot with education, or also telling them what questions to ask their providers. We dove into one of my commercial contracts and looked at the really big spenders. on bad postnatal outcomes. A smaller subset than I thought was preventable. And let me explain. Is we looked at our $200,000 and up claims, and a large number of those, probably the majority, are on very unfortunate congenital malformations where they have a certain syndrome. We try to get ahead of it, but that part's going to be inevitable. And a decent number are truly unexpected placental issues or the like. But I think you're touching on the subset of poorly controlled hypertension in pregnancy, diabetes, and like the chronic asthma revisits. And that, I discussed the gap earlier, is where Cheryl's team, backed up by the physicians, has really helped that population. Perhaps other people have a better assessment of the situation, but that is where I found that gap in the middle and the small number of poorly controlled conditions has been the places we can make the most difference. If somebody has a major congenital heart defect, we can line them up for care, but those at least tend to be identified. And while not totally inevitable, are at least something that's going to have to be dealt with at a specialty center beyond the ability of any remote or care management directly.
So maybe let's switch over to certification, right? I spoke very briefly. We went through the process to become NCQA certified for our care management services. So I really want to pose to Cheryl, one, why did we do that? Go through that process. That is kind of a lengthy process, but what are some of the benefits that we're seeing from that? What was the outcome of us going through that process and building and keeping an NCQA certified care management program?
Okay, so why population health? Well, as we approach this, we really wanted to identify our population, have a consistent way we look at our population and identifying how we can best support them. We wanted to make sure that we were following evidence-based guidelines and that we had a consistent process in which we were evaluating the needs of our population, regardless of whether they were a commercial or they were Medicare aged population. So we wanted to be able to identify what is the most important data that we should be looking at that's going to help us determine the distribution of our population related to health outcomes. While it's not the same with each payer or in each area that we are providing services, we wanted a baseline to be able to understand how we were going to look at that. Also, as we look at from a population health standpoint, and we look at our population distribution across many counties, states, wherever we're providing services, we wanted to be able to identify how to determine their social vulnerability or their SDOH needs and what are their risk factors. So we serve counties who have like the highest incident of COPD. And so our interventions for that population are going to be different than going to be for other populations that have a lower incident of COPD. And so part of that, again, with population health is to develop a program that's going to be consistent, that we can use to provide services across all types of folks, wherever we're serving them. We also know that provider groups this is kind of a gap area with decreased access and the strain on primary care providers. We wanted to be able to create a program that was going to be supportive to our independent practices as well as our bigger practices. Each practice has a different need. And so developing that relationship with each type of practice and understanding each one of their needs, because they're not all the same, and how we can help support them. And again, going back to a population health program that is consistent. And so we make sure that we can provide that overall program and just fill in the gaps if we need to, or are we providing the whole thing for those populations by the provider groups. Dr. Shannon, did you want to add anything to that?
No, I think you touched on the fact that each group may have different needs, and this is where when we partnered up with people and groups in say Florida or Minnesota and other states, where the person contracting with us, we usually sit and say, "Can you help us guide us to what's going to be necessary?" Which is, in our primary community, we have all these resources, but we've really struggled with behavioral health in this outlying community where we have a critical access hospital. I think we touched on earlier, we support about a dozen critical access hospitals in for Medicare populations with care management. Their needs are totally different. It's a humbling experience when you're a specialist in a city to realize patients have driven 3 hours to see you for a 15-minute visit. And that it's also going to be a lot of people who aren't going to make that drive at all. And those needs are different. And that is where Cheryl's team has partnered up with, say, a rural hospital in Eastern Washington to say, well, what do you need to get them into cardiology? And the answer is in the winter, they can't drive there. And that is where being able to personalize and sit with the group and Cheryl's team and our medical leadership to say, okay, those are issues I don't have. What can we do for this for virtual or the like? So that's where Cheryl's customization, especially supporting people outside of our traditional area and being able to find their needs differently and what their resources are has been important. Thanks, Cheryl.
I think when we talk about customization, right, and there's so many different elements, so many different things we could work on. I know for those maybe in the audience that know Melanie Matthews, our CEO, and some maybe don't, but what she always says to us is if we focus on everything, we focus on nothing. So it's very important for us to be strategic in how we look at the population, right? We talked about risk stratification. It's very important when we look at our efforts and what can we actually do, what can we influence with the population. And so thinking with some of these care management elements, and thinking about value-based programs for various types of providers and what could be high cost, I think another important piece is pharmacy. Pharmacy has the potential and high cost drugs can be huge and it can be a challenge with some of these programs. So I'm curious, Dr. Shannon, thinking, from your experience in the pharmacy space and working with care management, how does that interact? What are the programs, what is the possibility there to really benefit from the pharmacy side?
So great question. We did not really cover this. We do have managed care pharmacists that work on certain contracts depending on the terms. And there's a lot of elements to getting the pharmacy part right, because it's like in Medicare, when you have an expensive drug, remembering beyond us or beyond you, the payer or the system, the member is paying 20% of that. The difference between an Eylea injection and an Avastin in the eyes is $400 per shot for drugs that for most people can be used equivalent. So having our pharmacists go through and identify places to switch, or certain drugs are going to be cheaper on the medical benefit versus the pharmacy benefit. So when the member touches base with Cheryl's team and it's relayed up to us as the docs, it's bringing the pharmacist and saying, you know what, we could use this drug that's given as injection, but we could switch this to an oral and save the money. So managed care pharmacists have been helpful there for drug costs. The other part, and maybe this gets beyond, for certain contracts, we just do care management. For certain ones, we do more pop health services, is being able to look at groups. I'm going to finesse this statement. Groups with not a great tradition of cost-effective care. We have data we didn't discuss. We have medical economics, and actuaries, but for some of these, when it's deployed up, there are chronic offenders. And there are people who do not have a great tradition of cost-effective medicine. And we've used our pharmacists and that's for medical directors to get involved. And maybe have you decide, is this a group that if they won't engage belongs in your network? That's taking it from the care management to some of our other population health services that we do we have some care management only contracts and some that include medical directorship and pharmacy. But even if Cheryl's team, if we're just doing care management, we may relay to you, this is our 7th complaint about an inexpensive medication out of this one group, so that we have relayed those up even when we don't have those core responsibilities delegated to us. Thanks.
That's a great example. Okay, so in our last 3 minutes, I want to do a quick, less than a minute each on one question, and maybe I'll start with Dr. Shannon. Is what is missing from care management today? Like what has not been built yet?
By far, it is a way to digitize social determinants of health. So I did internal medicine, then geriatrics fellowship, and worked as a geriatrician before endocrine. And One of the best predictors of hospital admits is going to be being recently widowed, widowered, or separated for a Medicare patient. Super high predictor, especially for recently widowered men. When I worked at the VA for 6 years, and that is a super high predictor. Our computer system could take a look at somebody's history of ER visits and pick up readmit rate. We're trying to dig into this with tools like census tracts, and those have use to them. But in the end, we have an imperfect way to get to things like, how many friends do you have? How many times do you go out? How many people could you call in an emergency? Do you have someone in your life who loves you? And those are powerful predictors that so far have not lent themselves to big data yet perfectly. And I hope that will come, because that's going to get a lot of people for whom their FEV1 on their COPD is not cutting it. Thanks.
Cheryl, 30 seconds.
That's really great, Dr. Shannon. I 100% agree with you that, as we are looking at those who are at risk, we have, the elderly female who has been admitted for acute care, and her husband who has dementia is left at home. Who's taking care of him? There's all sorts of stories or things that we've come across in care management that have been concerning, that would be important for us to be able to identify before they happen, because when it happens, you still have the gentleman at home who has no family near him, who's trying, the wife is in the hospital, or vice versa, they're admitted into the skilled nursing facility. And so the person who's the primary caregiver, or the primary caregiver has had an issue and now can't provide care to that loved one that they've been taking care of. And then things start to go sideways. So I agree with you, Dr. Shannon. That's a huge area where we can continue to look at and build our care management services.
Great. Well, we really want to thank everyone for joining us today. This was a lot of fun for us. Really want to send a huge thank you to Innovacer for helping support that. For any of you that are interested in learning more about our care management services and how we could potentially support your programs, whether you're stepping into risk, been in for a while, and you're getting beefed up in your programs, whatever it may be, please feel free to reach out. We're happy to help and take a look at help people build their programs and also support with our current services. So you can see my contact info on the screen, jacobw@pswipa.com. Please feel free to reach out. And we thank you all for joining us today and wish you all a wonderful week.
Thank you.